Welcome back, everyone. In continuation of the last lecture, we begin our discussion on laboratory investigations. The most important laboratory test is the measurement of high sensitivity cardiac troponin. Troponin is the preferred biomarker for detecting myocardial damage. The recommended protocol is to measure troponin at presentation, which is 0 hours, and repeated 2 hours later. A rise or fall in troponin levels strongly supports the diagnosis of acute myocardial infarction. Additional blood tests include a complete blood count, coagulation studies such as INR and partial thromboplastin time, electrolytes, magnesium, creatinine, blood urea, blood glucose, and serum lipid profile. These investigations identify contributing conditions, elevate renal function before contrast administration, assess bleeding risk, and detect cardiovascular risk factors. The lipid profile should ideally be obtained within 24 to 48 hours after the onset of myocardial infarction because cholesterol levels become unreliable after the first 2 days. Management of acute coronary syndrome. General measures. Number 1. Management begins with the ABC approach: airway, breathing, and circulation. The patient's hemodynamic status should be assessed and corrected immediately. The patient should remain on bed rest with continuous cardiac monitoring. Oxygen is administered only when indicated, such as in patients with hypoxemia. For chest pain relief, sublingual nitroglycerin is given first, followed by intravenous nitroglycerin if symptoms persist and blood pressure permits. Morphine may be used for severe pain that is not adequately relieved by nitrates. Number 2, antiplatelet and anticoagulation therapy. Antiplatelet therapy should be started as early as possible. Every patient receives chewed aspirin unless there is a contraindication. For NSMI, treatment consists of ticagrelor plus aspirin together with the anticoagulation using low molecular weight heparin, usually enoxaparin or unfractionated heparin. In Canada, fondaparinux is also commonly used for the initial management of NSMI and unstable angina. If the patient cannot receive ticagrelor, clopidogrel is the preferred alternative. When PCI is planned, ticagrelor or prasugrel is preferred because they provide a stronger platelet inhibition. Intravenous glycoprotein 2B or 3A inhibitors such as ipdifipatide or tirofiban may be used in selected high-risk patients during PCI. Remember that prasugrel is contraindicated in patients with a history of a stroke or transient ischemic attack, and it should be avoided or used cautiously in patients older than 75 years or weighing less than 60 kilograms. Anticoagulation according to reperfusion strategy. The anticoagulant depends on the reperfusion strategy. During primary PCI, unfractionated heparin is commonly used. For patients receiving thrombolysis, enoxaparin is continued until hospital discharge. Patients managed without reperfusion also receive enoxaparin until discharge. Patients at high risk of thromboembolism, such as those with arterial fibrillation or ventricular thrombose, may require oral anticoagulation after discharge. 3. Beta blockers. Beta blockers reduce myocardial oxygen demand by decreasing heart rate and blood pressure. They should be started within the first 24 hours unless contraindicated. Contraindications include heart failure, cardiogenic shock, severe bradycardia, heart block, asthma, or significant airway disease. If beta blockers cannot be used and ischemia persists, verapamil or diltiazem may be considered, provided there is no severe left ventricular dysfunction. 4. Invasive strategies and reperfusion. Patients with unstable angina or NSTMI should undergo early coronary angiography with possible revascularization if they have high-risk features including confirmed NSTMI, recurrent angina despite medical therapy, heart failure or left ventricular dysfunction, hemodynamic instability, high TIMI score, Grace score greater than 140, sustained ventricular tachycardia, dynamic ECG changes, high-risk stress test findings, recent PCI, and recurrent ACS admissions. Finally, remember one very important examination point. Thrombolytic therapy is not indicated for unstable angina or NSTMI. It is used only for STMI when primary PCI cannot be performed promptly. TIMI score. The TIMI risk score estimates the risk of death or recurrent ischemic events in patients with unstable angina and NSTMI. 1 point is assigned for each of the following: age 65 years or older, 3 or more coronary artery diseases risk factors, known coronary artery disease, aspirin used within the previous 7 days, 2 or more anginal episodes in the past 24 hours, ST segment deviation, elevated cardiac biomarkers. A TIMI score of 3 or more identifies high-risk patients who benefit from early invasive management. Complete trial. The complete trial showed that in patients with STMI and multivessel coronary artery disease, complete revascularization treating both the culprit lesion and the significant non-culprit lesion reduces cardiovascular death and recurrent myocardial infarction compared with the treating only the culprit artery. In summary, sorry for that. In acute coronary syndrome, remember the sequence. Confirm the diagnosis with troponin and ECG. Stabilize the patient. Start aspirin and dual antiplatelet therapy. Choose anticoagulation based on the reperfusion strategy. Initiate beta blockers when appropriate and identify high-risk patients for early coronary angiography and complete revascularization. Now let's discuss the management of ST segment elevation myocardial infarction or STMI. Once STMI is diagnosed, do not delay reperfusion therapy while waiting for additional investigations. Remember the phase, time is muscle, every minute of delay leads to more myocardial damage. The treatment goal is rapid restoration of coronary blood flow. This can be achieved either with the fibrinolytic therapy, aiming for an EMS to needle time of less than 30 minutes, or with primary percutaneous coronary intervention, or primary PCI, aiming for an EMS to balloon time of less than 90 minutes when PCI is available. Primary PCI. Primary PCI is preferred perfusion strategy when it can be performed quickly in an experienced PCI center. Early PCI, ideal within 12 hours of symptom onset and within 90 minutes after hospital presentation, reduces mortality, lowers the risk of recurrent myocardial infarction, and causes fewer intracranial hemorrhages than thrombolytic therapy. If thrombolysis has already been given but fails, meaning the ST segment elevation decreases by less than 50% within about 60 to 90 minutes, and the patient continues to have chest pain, the patient should undergo rescue PCI. If primary PCI cannot be performed within 120 minutes of STMI diagnosis and the patient has no contraindications, fibrinolytic therapy should be administered, provided symptoms onset was within the previous 12 hours. Keep in mind that the benefit of thrombolysis decreases as time from symptom onset increases. Therefore, in patients prescribing later, especially after 3 hours, primary PCI becomes increasingly preferable whenever feasible. STMI reperfusion algorithm. Let's briefly review the reperfusion pathway. If STMI is diagnosed at a non-PCI hospital or by emergency medical services, first determine whether the patient can reach a PCI center and receive PCI within 120 minutes of the first medical contact. If yes, immediately transfer the patient for primary PCI, aiming for a transfer time of less than 60 minutes and a first medical contact to PCI time of less than 120 minutes. If no, administer fibrinolytic therapy within 30 minutes of the first medical contact. After successful thrombolysis, the patient should still be transferred routinely for coronary angiography and PCI within the next 24 hours. If thrombolysis fails, the patient requires immediate rescue PCI. Patients who initially present directly to a PCI-capable hospital should proceed straight to primary PCI, with a target first medical contact to PCI time of less than 90 minutes. Contraindications to thrombolysis. Before aiming fibrinolytic therapy, always assess for contraindications. Absolute contraindications include previous intracranial hemorrhage, known cerebral vascular malformation, intracranial malignant tumor, significant head or facial trauma within the past 3 months, ischemic stroke within the past 3 months, active bleeding, and suspected aortic dissection. Relative contraindications include severe or poorly controlled hypertension, blood pressure greater than 180 over 110 millimeters of mercury, current anticoagulant therapy, recent non-compressible vascular puncture, ischemic stroke older than 3 months, recent internal bleeding within the previous 2 to 4 weeks, recent prolonged CPR or major surgery within the previous 3 weeks, pregnancy, and active hepatic ulcer. These conditions increase the risk of serious bleeding and must be carefully weighed against the benefits of thrombolysis. Long-term management of acute coronary syndrome. After the acute event, long-term management becomes essential. The risk of recurrent myocardial infarction or death is high during the first month after the initial event. By 1 to 3 months, many patients begin to follow a clinical course similar to those with chronic stable coronary artery disease. Before discharge, patients should undergo an electrocardiogram and echocardiogram to assess residual left ventricular systolic function. Any medications started during hospitalizations to control ischemia should generally be continued after discharge unless contraindicated. Finally, long-term management focuses on general preventive measures including patient education about their disease, aggressive modification of cardiovascular risk factors such as smoking cessation, blood pressure control, diabetes management, cholesterol reduction, healthy diet, regular physical activity, and adherence to prescribed medications. In summary, the priorities in STMI management are rapid reperfusion, selecting the appropriate reperfusion strategy based on timing and PCI availability, recognizing contraindications to thrombolysis and ensuring comprehensive secondary preventions after discharge. Antiplatelet and anticoagulation therapy. Dual antiplatelet therapy is a cornerstone of STMI treatment. Every patient should receive ASA or aspirin 81 milligrams once daily indefinitely unless contraindicated. A second antiplatelet agent should be added. The preferred options are ticagrelor 90 milligrams twice daily or prasugrel 10 milligrams once daily. Treatment should continue for at least 1 month and typically 9 to 12 months. If a coronary stent has been placed, dual antiplatelet therapy should continue for at least 12 months. If ticagrelor or prasugrel cannot be used, clopidogrel 75 milligrams daily is an appropriate alternative. Some patients also require anticoagulation. Warfarin with a target INR between 2 and 3 is recommended for high-risk patients, particularly those with a large anterior myocardial infarction, left ventricular thrombus, left ventricular ejection fraction below 30%, a history of venous thromboembolism, or coronary atrial fibrillation. Another option is rivaroxaban, 2.5 milligrams twice daily, based on evidence from the COMPASS trial. 3. Beta blockers. Next are beta blockers such as metoprolol 25 to 50 milligrams twice daily or atenolol 50 to 10 milligrams once daily. These drugs reduce myocardial oxygen demand, decrease heart rate and blood pressure, reduce the risk of recurrent ischemia and arrhythmias, and improve long-term survival after myocardial infarction. Nitrates. Nitrates are effective for relieving chest pain and myocardial ischemia. However, they do not improve mortality or long-term outcomes. Use nitrates cautiously in right ventricular infarction because these patients are preload dependent. Excessive vasodilation may cause severe hypotension. Calcium channel blockers. Calcium channel blockers are not recommended as first-line therapy of STMI. They may be considered when beta blockers are contraindicated or not tolerated, but they should not replace evidence-based therapies. ACE inhibitors. ACE inhibitors play an important role in preventing adverse ventricular remodeling following myocardial infarction. They are recommended for asymptomatic high-risk patients such as those with diabetes, even if the ejection fraction is above 40%, patients with symptomatic heart failure, reduced left ventricular ejection fraction below 40%, or those with an anterior myocardial infarction. If ACE inhibitors are not tolerated, angiotensin receptor blockers or ARBs should be used instead. Remember, ACE inhibitors and ARBs should not be combined because this increases adverse effects without additional benefit. Aldosterone antagonists. Patients who are already receiving an ACE inhibitor and a beta blocker and who have a left ventricular ejection fraction below 40% plus heart failure or diabetes should receive an aldosterone antagonist such as eplerenone, ideally within 30 days of the myocardial infarction, as it significantly reduces mortality. Lipid-lowering therapy. Every STMI patient should receive high-intensity statin therapy, for example, atorvastatin, 80 milligrams daily. If LDL cholesterol remains above target despite maximal statin therapy, ezetimibe or a PCSK9 inhibitor can be added. According to the Canadian Cardiovascular Society guidelines, the target LDL cholesterol is less than 1.8 millimoles per liter. Invasive cardiac catheterization. Finally, invasive cardiac catheterization is used for post-myocardial infarction risk stratification. Patients with high risk features, including previous myocardial infarction, congestive heart failure, recurrent ischemia, or high-risk ventricular arrhythmias, should be proceed directly to cardiac catheterization. Patients at an intermediate or low risk should first undergo non-invasive stress testing. If a stress testing shows ischemia or poor functional capacity, cardiac catheterization is indicated. If a stress testing is normal, no further evaluation is required at that time. Prognosis of following STMI. Let's finish with prognosis. Approximately 5 to 15% of hospitalized STMI patients die during their hospital stay. Factors associated with the worst prognosis include a large infarct size, older age, multiple comorbid conditions, development of heart failure, and hypotension. After discharge, mortality remains significant. Approximately 6 to 8% die within the first year, with the half of these deaths occurring in the first 3 months. After the first year, the mortality rate is about 4% per year. Poor long-term prognostic factors include left ventricular dysfunction, residual myocardial ischemia, ventricular arrhythmias, and a previous history of myocardial infarction. High-yield clinical perils. Before we conclude, remember these key exam points. Aspirin is continued for life after STMI. Dual antiplatelet therapy usually continues for 12 months, especially after a stent placement. Beta blockers, ACE inhibitors, aldosterone antagonists, and high-intensity statins all improve survival. Nitrates relieve symptoms but do not reduce mortality. Right ventricular infarction requires caution with nitrates because patients are preload dependent. Resting left ventricular ejection fraction is one of the strongest predictors of prognosis after myocardial infarction. Complications of myocardial infarction. Following an acute myocardial infarction, patients are at risk for several serious complications. The timing of these complications is clinically important because it helps us anticipate and recognize them early. The first complication is arrhythmias, which are the most common early complication. Tachyarrhythmias including sinus tachycardia, atrial fibrillation, ventricular tachycardia, and ventricular fibrillation usually occur during the first 48 hours after myocardial infarction. Ventricular fibrillation is particularly dangerous because it can cause sudden cardiac death and requires immediate defibrillation. Bradyarrhythmias such as sinus bradycardia and atrioventricular block also commonly occur within the first 48 hours, especially in inferior wall myocardial infarction. Management depends on the type of rhythm disturbance and may include atropine or temporary pacing. Next is myocardial rupture, one of the most catastrophic complications typically occurring 1 to 7 days after infarction. After ventricular free wall rupture usually follows a transmural infarction and can rapidly lead to cardiac tamponade and sudden death. Emergency surgery is required at this point. A papillary muscle rupture, most commonly after an inferior myocardial infarction, causes acute cerebral mitral regurgitation, leading to pulmonary edema and cardiogenic shock. This also requires urgent surgical repair. A ventricular septal rupture results in a ventricular septal defect, producing a new harsh systolic murmur and heart failure. Again, surgical correction is the definitive treatment. Another serious complication is cardiogenic shock due to left ventricular failure, which generally develops within the first 48 hours after a large infarction. Management includes inotropic support, hemodynamic stabilization, and sometimes an intra-aortic balloon pump. Patients may also develop post-infarction angina caused by persistent coronary stenosis of multivessel disease. It can occur at any time after the infarction and is managed with aggressive medical therapy followed by PCI or CABG if indicated. Similarly, recurrent myocardial infarction occurs because of a reocclusion of the infarct-related artery and also requires aggressive medical treatment with possible revascularization. Thromboembolism usually develops between 7 and 10 days, although the risk may persist for up to 6 months. It results from mural thrombose formation in the left ventricle or from deep vein thrombosis, and anticoagulation is the treatment of choice. Pericarditis is an inflammatory complication occurring 1 to 7 days after myocardial infarction and is treated with aspirin. Finally, Dressler syndrome is a delayed autoimmune form of pericarditis that typically develops 2 to 8 weeks after infarction. Treatment of anastomie. A useful mnemonic for anastomie management is BEMOAN, B-E-M-O-A-N. B stands for beta blockers, E stands for enoxaparin, an anticoagulant, M stands for morphine for persistent pain, O stands for oxygen but only if the patient is hypoxic, A stands for aspirin, and N stands for nitrates, unless contraindicated. Remember, the major contraindications to nitrates include severe aortic stenosis, hypertrophic obstructive cardiomyopathy, suspected right ventricular infarction, hypotension marked by bradycardia or tachycardia, and recent use of phosphodiesterase 5 inhibitors such as sildenafil. Treatment algorithm for acute coronary syndrome. Let's now talk through the management algorithm for patients presenting with symptoms suggestive of acute coronary syndrome. The process begins with the recognition of symptoms such as chest pain or other features suggestive of myocardial ischemia or infarction. Step 1. EMS and pre-hospital care. Immediate management starts before the patient reaches the hospital. Emergency medical service should monitor the patient, prepare for CPR and defibrillation if necessary, and obtain a 12-lead ECG. If SMI is identified, the receiving hospital should be notified immediately. Initial medications include aspirin, oxygen if hypoxemic, sublingual nitroglycerin when appropriate, and morphine for ongoing pain. Step 2. Emergency department assessment. On arrival, the priority is rapid evaluation. A 12-lead ECG should be obtained within 10 minutes if it was not performed pre-hospital. Intravenous access is established. Aspirin is administered if not already given. Oxygen is titrated only when oxygen saturation is below about 94%. Nitroglycerin is given unless contraindicated, and morphine may be used for persistent pain. At the same time, obtain a focused history and physical examination, review contraindications to fibrinolysis, order cardiac biomarkers, electrolytes, coagulation study, and obtain a portable chest X-ray when appropriate. Step 3. Interpret the ECG. The ECG guides further management into 3 possible pathways. STMI. If the ECG shows ST segment elevation, begin immediate therapy with anticoagulation, nitrates, and beta blockers when appropriate. But the priority is urgent reperfusion. If symptoms begin within 12 hours, the preferred strategy is primary PCI with the goal door-to-balloon time of 90 minutes. If PCI cannot be performed promptly, fibrinolytic therapy should be administered with the 30 minutes, provided there are no contraindications. STMI. If the ECG shows ST segment depression or elevated troponin without ST elevation, the patient is managed as STMI. Patients with high-risk features including persistent chest pain, ongoing ST depression, hemodynamic instability, heart failure, or ventricular tachycardia should undergo an early invasive strategy. Adjunctive therapies include nitroglycerin, intravenous heparin, beta blockers when appropriate, clopidogrel, and in selected patients, glycoprotein 2B3A inhibitors. Patients are admitted to a monitored bed and receive continued aspirin, anticoagulation, ACE inhibitors or ARBCs, and high-intensity statin therapy, while cardiology evaluates the need for coronary angiography and possible revascularization. Normal ECG. If the ECG is initially normal, the patient is observed with the serial ECG and repeat cardiac biomarkers. Further evaluation with non-invasive stress testing may be performed. If the patient develops ECG changes, elevated troponin levels, worsening chest pain, or arrhythmias, management shifts toward the STMI pathway. If all investigations remain normal and the stress testing is negative, the patient can be safely discharged with outpatient follow-up. To summarize, Most life-threatening complications of myocardial infarction occur during the first week, making close monitoring essential. Mechanical complications including ventricular free wall rupture, papillary muscle rupture, and ventricular septal rupture typically occur 1 to 7 days after myocardial infarction and require urgent surgery. Initial ACS management always includes rapid ECG acquisition, aspirin, appropriate anti-ischemic therapy, and early risk stratification. STEMI requires immediate perfusion, whereas NSTEMI management focuses on aggressive medical therapy and early invasive evaluation for high-risk patients. Early recognition and timely intervention significantly reduce mortality and improve long-term outcomes. Thanks for attending the lecture. If you're new to the channel, don't forget to like and subscribe and press the bell icon. See you in the next lectures.